Dr. GURUPRASAD to speak to us on dumbbell technique, scale fixated IOL. Over to you, sir.
Dr. Deepak, you said so far so good, but then they are at a very young age. We don't know what will happen when they become adults and maybe 40, 50. So I think at that time we should be mentally prepared, or at least counsel the patients, parents, that they might need another surgery. I think that's important. Okay. Thank you, APAO, and thank you, Dr. Satyamurthy, for involving me in this very nice symposium on IOLs. I'll be sharing my technique, which I've been doing for the last 4 years, and I found it to be extremely simple, extremely predictable, and without complications. आगे नहीं चल रहा है. Yeah. So the common indications of a secondary IOL, I think I will not go into these details because I think everyone knows, and part of it has already been covered in the previous talks. So the most important message that I want to give here is that any unplanned aphakia, as in a large PC rent occurring due to any of the multiple causes during cataract surgery, that holds good for all secondary IOLs, even the iris claw lens, and in case of Marfan syndrome. These are the two indications, incidentally, which are my major indications for the dumbbell technique, which I'm going to talk about. And these are the prerequisites for before you plan the implantation. I think I'll not go into these details again. So the first, among the numerous techniques that we have in our armamentarium today, I am going to speak on 4-flange technique, also called the dumbbell technique, using 6-0 prolene. I think dumbbell technique, which Sergio Canabrava actually innovated, was with the 5-0, but I found that 5-0 doesn't give me as good predictable results and as good centration as 6-0 does, and therefore I am using 6-0 with a rigid IOL. So this is the schematic of the Sergio Canabrava technique, the Brazilian surgeon, and this is the surgical video of what I do, making conjunctival incisions at 3 and 9 o'clock positions in an aphakic eye which has been left aphakic in a camp patient, and opening the tunnel, reopening the tunnel, the previous tunnel, which is just about a month, which is fresh and just about a month old. And these are the cauterization steps which we have to do very minimally to keep the sclera tough. The tunnel has to be reopened, and I put in an infusion in most of my patients. I'm a VR surgeon and I'm not scared of the pars plana. I put in an infusion and just use it now and then to restore the IOP when the eye becomes soft. And this is the Hoffman's pouch that I'm creating on both sides. This is the left side Hoffman's pouch, which I use to cover the flange on the left, and the similar one on the right. This is the right eye, and that is the Hoffman's pouch on the right hand side. This has to be very superficial because the flap has to be thin, but the bed has to be thick because the flange has to be held well. I opened the incision now, and I am doing anti-vitrectomy both outside the eye and inside the eye now. The pupil has to be clear, and there should not be any strand of vitreous left behind, although you can resume the vitrectomy once the lens has been placed. This is the 6-0 suture I was talking about, which I place through the 30 gauge needle, and not all 30 gauge needles are of good quality. We have to be wary of that and get this suture out. It's a 4 centimeter suture, simple suture without needles, and that is the suture coming out from the wound. And similarly on the other side, I diametrically opposite point, I use the incision to be passed, the needle to be passed, and get the suture out from the other side. And when the two sutures are out and the two ends of the scleral side are also out, I cauterize the scleral side of the suture just to ensure that it doesn't slip back into the vitreous cavity. that is the other end being sutured. And this I'm using a Bowie cautery, which is just a simple device which is available commercially nowadays very freely, and which runs on battery. This is the lens, the standard rigid lens I was talking about, which I use. I put in the other end, the scleral incision wound and the SICS wound end of the suture, and that I also cauterize and make it as flange. And I take care to see that the flange is on the lower surface of the iris when I implant it, lower surface of the IOL, not rubbing against the iris. So that's very important to do, because otherwise the dumbbell, the flange can rub against the iris and cause chronic cyclitis. So this is the other end of the suture through the other eyelet of the SFIOL, and I guide both of them at the same time, pulling the suture out so that the lens does not sink to the bottom and there is no need to pull it out again. This is the laser which I am using this time. Just to show you this, I am using doing it just to show you that laser also can be done to create the flange and not the cautery all the time. The cautery is of course good. Sometimes if the battery is weak, it may not work. If you have a laser in a full-fledged VR setup, we always set up the vitrectomy machine for other cases, and that is always available in our center. So that is the flanging that we do with the laser. Now the suture is, the wound is closed. I open the infusion now and then just to restore the IOP I was telling you. And this is the tightening of the suture. I like to keep it little tight so that we have an astigmatism which can be controlled over time. So at the end of 2 months, I decide whether to cut the suture or leave it like that, depending on what astigmatism the patient ends up with. And this is the final result. So this is the dumbbell technique. But I'm going to show you one more technique since I have time of 8 minutes. A technique where I have used the dumbbell technique which I use for dislocated IOLs, totally dislocated into the vitreous cavity. What happens is usually after 9 to 10 years of scleral fixation done with the 90 prolene, there is a biodegradation that happens, and that causes dislocation of the IOL, either one side or both sides, and the lens is seen in the vitreous cavity. Patient comes with sudden loss of vision. So this is the similar technique that I'm going to do for the dislocated IOL, except that I do it in a closed manner. Closed eye refixation, as I call it, is this technique where I thread the suture through the eyelet in the vitreous cavity using chandelier illumination. And since I have a good VR setup in my institute, I'm able to do this. And this also I have done about 8 cases so far, and they're all doing very well. Similar technique here, I'm using 26 gauge needles. I don't know for what reason. I think it was probably because the 30 gauge needles were not of good quality at that point of time. The other, I'm sorry about the glare, but you could see the shadow there, and similar threading of the eyelet was done, and this is the flanging. So basically the technique is the same, except that it is done intravitreally using laser to flange it, and that is the end of the surgery. So the most important thing is to prevent a slack. You have to pull the thread which is out of the 3 and 9 o'clock positions. Sclerotomy is very hard, so that you don't have any slack inside the eye, and then cut about 4 millimeters of, leave just about 4 millimeters of suture and cauterize that point. That is good enough to cause, to create a good flange for you to prevent slipping into the vitreous cavity. I think with that I conclude. Thank you very much.
Thank you, sir. That was a nice demonstration. One question until Dr. Srinivas gets ready. What is the longest follow-up that you have with this particular technique?
4 years since I started this. My longest follow-up is 4 years, and these patients are really doing extremely well. They somehow, all the other complications which we used to have with the 9-0 suturing method are not there with the 6-0, I'm unable to explain why they don't have these complications. It's good to have no complications, but the reason why I am not able to explain it is probably because of the short suture and maybe the scleral bite is not there. Maybe the panelists can also contribute to why there is no reaction. So it's a reactionless post-operative course.
Yeah. Do you feel 6-0, I mean proline, it lasts for a longer period than 9-0?
Of course, it does. I mean, that is what I imagine. 9-0 definitely biodegrades in about 10 to 12 years. I've seen all my patients coming back now with dislocated either one side or others or both sides, dislocated IOLs, and I have had to redo with using this technique now, using 6-0. I tell them that I've got better sutures now and I'm doing this for you this time. So that is the scenario. Being thicker, I think it should be less biodegradable. It may last for 20 years, if not more. That's what I imagine. But let us see what others have to say.
And what should be the size of flange on either side of the?
On one side, on the IOL side, it should be big enough to not to pass out or slip through the eyelet. That we check it while before implanting. And on the scleral side, it need not be very. I'm not very strict about the size because over time the sclerotomy, the passage through the sclera would heal and also get integrated with the flange. I think that's okay to hold the lens. Yeah.
Thank you, sir. Any other questions?
It's not as good as 30 gauge. 30 gauge is always better because opening is larger, so the flange has to be bigger. And one more thing, glue. I forgot to tell you that glue is better in all these SFIOLs where you make multiple scleral openings because it sort of makes it watertight rather than just leaving it to the healing process, which is sometimes delayed and patients have post-operative hypotony. I think we should have glue, and glue really makes it firm the next day. Next day you will find the eye very firm and without any hypotony.
Yeah. Thank you, sir.